看到吗？
我看到。
Okay. Good morning, professors and everyone. I'm third year resident, Guo Xiaorui. Today, I'm going to present the research published on Journal of Craniomaxillofacial Surgery in December 2021. Higher need for removal of osteosynthesis material after multi-piece versus one-piece level 1 osteotomy. A retrospective study of 339 patients. And first of all, we'll start from the brief introduction. One-piece level 1 osteotomy was used to create vertical and sagittal movement of maxilla. It is frequently performed to correct skeletal class 2 or 3 malocclusion, vertical maxillary excess, and hypoplasia. However, level 1 osteotomy is limited in correcting an anterior or lateral open bite and severe anterior dental inclination.
Hello， 小瑞，断线。
不好意思，刚好像断线。
再一次。
OK。那刚刚是讲到，
从这边开始。
Okay. An alternative to level 1 osteotomy is a multi-piece osteotomy, which allows transversal maxillary movement independently for each surgical segment, besides the vertical and sagittal movements. An noticeable difference in the occlusal planes of the labial and buccal segments, or correction of severe anterior inclination of the incisors, are additional indication for multi-piece level 1. For example, when patients present with severe dental crowding or lateral crossbites caused by a narrow palate, two treatment options are suggested. The first one is two-stage operation, starting with surgical assist rapid palatal expansion, which called SARP, followed by level 1 operation. Or the second one is one-stage multi-piece level 1 osteotomy. Both can be combined with bilateral sagittal split osteotomy, so-called BSSO, depending on the degree of skeletal discrepancy. But one-stage multi-piece level 1 is preferred in order to avoid possible additional complications with a two-stage approach. So the post-operative complication rates of multi-piece level 1 vary from 8.5 to 27%, and mostly include infections, oral enteral communications, and damage to adjacent teeth. And the removal of osteosynthesis material is indicated in infections or subjective complaints, such as pain, discomfort, or paresthesia. Therefore, the aim of the present study was to report the incidence of osteosynthesis material removal after multi-piece level 1 osteotomy compared to standard level 1 osteotomy. And the other one is to identify potential risk factor for multi-piece osteotomies that are predictive for plates removal. So next we'll move to the patient and methods. To briefly introduce the multi-piece and standard level 1 osteotomy, I found some picture from AO surgery reference. On the left side, these are the standard level 1 osteotomy that we usually do. Then if we section the maxilla into multiple pieces from 2 to 5 pieces, in order to perform further transversal movement, these are the osteotomy line according to the statement in this study. And as for the study design, clinical records and radiographic data for patients undergoing one-piece or multi-piece level 1 osteotomy were reviewed retrospectively from February 2013 to March 2019 at the Department of Oral and Maxillofacial Surgery in University Hospital Leuven, Belgium. Patients diagnosed with craniofacial syndromes, clefts or palates, major trauma, and systemic disease were excluded. And KLS 2.0 fixation material was used in all patients treated with a multi-piece osteotomy or level 1 osteotomy, including titanium L plates, horizontal plates, and single screw in order to breach the osseous discontinuity cape and fixates the iliac crest-bone graft if used. All procedures were performed by the same surgical team following the same protocol as below for all patients. And patient records were reviewed for patient demographics, pre-operative diagnosis, previous SARP intervention, number of maxillary osteotomy pieces, intraoperative autologous bone graft usage, simultaneous BSSO procedure, and complication associated with the osteosynthesis material removal. And transverse maxillary expansion or impaction was measured linearly from the pre-operative cone beam CT image used for the 3D virtual planning. And the distance between the outer cuspid for the first left and right molars was also measured pre-operative based on the 3D planning. And the difference between these two linear measures indicates posterior expansion and impatience. The main outcome variable was the removal of osteosynthesis material, and the secondary outcomes were indication for osteosynthesis removal, time between insertion and removal, the number of plates removed, the occurrence of postoperative infection, subjective irritation, and pain or paresthesia. Osteosynthesis material was removed only if removal was indicated because of infection at the surgical site or because of subjective complaints. And the diagnosis of post-operative infection was made in the presence of purulent secretion, edema or induration with erythema, plaque exposure with pus, pain or granulation tissue or intraoral fistula. And the picture, for example, here we can see the plaque exposure on the patient undergoing multi-piece level 1 osteotomy. And the pain or discomfort was defined as subjective complaints without clinical signs of infection or inflammation. Subjective criteria for discomfort were palpability of the plates, tenderness or stiffness at the level of the plates. And the paresthesia was defined without improvement after more than 3 months following surgery. And these are the statistical analysis method in the study. So here are the results. A total of 339 patients were included in this study, including 49 who underwent multi-piece level 1 osteotomy and 290 who underwent one-piece level 1 osteotomy. Among the all, 21 patients after multi-piece level 1 and 46 patients after one-piece level 1 osteotomy needed removal of osteosynthesis material from the maxilla. And among these patients, over 65% were received plate removal within first year after the surgery in both groups. The two surgery groups did not differ regarding age, sex, occlusion class, prior history of SAR procedure, or removal indications. But the amounts of the osteosynthesis material used, number of patients who needed osteosynthesis removal, number of plates removed, and simultaneous BSSO differed significantly between these two groups. And the amounts of removed osteosynthesis material significantly correlated with the total amount of placed osteosynthesis material. The odds ratio of the osteosynthesis material removal after multi-piece level 1 was 3.98, which was higher compared to standard level 1 surgery, with an relative risk of 2.7. And the number of plates used to correlated with a significantly higher number of plates removed, and it was with odds ratio of 1.5. In the univariate analysis, a patient treated with multi-piece level 1, osteosynthesis material removal was associated with simultaneous BSSO and no history of preoperative SARP. And the multivariate analysis for multi-piece level 1 osteotomy showed a significant association with age, simultaneous BSSO, and previous SARP. The R-square was 0.29. And the relative risk of osteosynthesis material removal after multi-piece level 1 for simultaneous BSSO and previous SARP was 3.2 and 2.6 respectively, with significant risk. And the amount of maxillary expansions or intrusion and the indication for removal in multi-piece level 1 was not associated with increased incident of osteosynthesis material removal, regardless of prior SARP procedure. And only the osteosynthesis material removal rates in the maxilla differed significantly between two groups. Finally, we can see sex, pre-operative occlusion class, simultaneously BSSO, number of plates used, and number of pieces were not significant factors in multi-piece level 1 osteotomy, no matter previous SAR procedure was performed or not. So finally is the discussion of this study. The removal rates after multi-piece level 1 osteotomy was found significantly and almost 3 times higher than one-piece level 1 osteotomy. And also, there was more plates removed after multi-piece level 1. Regarding the type of surgery, multi-piece level 1 surgery requires significantly more plates than standard level 1 osteotomy for stability. And furthermore, plates positioning in multi-piece level 1 may be anatomically or technically more difficult to position. Therefore, there is a chance that the consequence would be exposure and subsequent need to removal. Among the group of patients who underwent a multi-piece osteotomy, higher removal rates could be identified according to age, simultaneous BSSO and no prior SARP procedure. In orthogenetic surgery, patient age has been correlated with an increased risk of complication and thus higher removal rates of hardware material, and these studies support this finding. And moreover, because of its highest odds ratio, simultaneous BSSO procedure with multi-piece osteotomies has been found to be the largest contributor to osteosynthesis removal. And the infection is an indication for plate removal and occurs more frequently after lower jaw surgery than upper jaw surgery. So it is possible that level 1 osteotomy and standard level 1 osteotomy and multi-piece level 1 osteotomy with simultaneous BSSO may have a higher incidence of infection and be more susceptible to removal of the plates. However, incident of relapse, analysis of maxillary perfusion, closure of diastemas, and postoperative orthodontic follow-up were outside the scope of this research. But there is still a possibility that this factor can influence the plate's removal rates. Relapse causes increased movement to the operated joint and could be one reason for osteosynthesis material causing annoyance and problems. Regarding relapse in multiplanar movements, no significant difference was found in level 1 osteotomy compared to a multi-piece osteotomy according to previous literature. And another influential factor, according to the previous literature, is that multi-piece level 1 osteotomy leads to a significant reduction in maxillary perfusion compared to standard level 1 osteotomy. And in this study, the mean level of posterior expansion during multi-piece level 1 with previous SARP was 0.9 millimeter lower than without previous SARP. This may also explain the different removal rates between multi-piece level 1 with or without previous SARP procedure. And to confirm the hypothesis that previous SARP and level of posterior expansion influence maxillary perfusion, the future work need to measure the prospective, operative, intraoperative, and postoperative pop blood flow via lesser Doppler flow meter, and it was need to be acquired. So this study also has some limitation that should be acknowledged. First, the relatively small number of patients treated with multi-piece level 1 osteotomy restricted the accuracy of the equation to standard one. In particular, the number of complications was relatively very low. The second limitation is that only KLS 2.0 plates were used, and therefore there was no comparison with KLS 1.5 plates. And finally, the reported association was found to be significant in the multivariate model, but the R-square of the multivariate model was only modest. And it suggests that other coexisting factors can play a role in indication for plate removal. So to conclude this study, it demonstrated significantly higher removal
我也是。 博医师，喂，博医师，
Okay.
博医师那
Let's
个
get back
对，
to the conclusion.
从 conclusion 对，
Okay. This study demonstrated significantly higher removal rates of osteosynthesis material after multi-piece level 1 compared to one-piece level 1 osteotomy due to complaints or occurrence of infection. And within the limitation of the study, patients who must undergo a segmentation of the maxilla should be informed before the start of the treatment that there is a high possibility that a second intervention for the removal of the osteosynthesis plates will be needed. So this is the end of my presentation. Sorry for the internet problem. Thank you for your attention. Is there any question or comments?
博医师他这里面有没有提到那个 plate removal 的时间点，就是在术后的什么时间点？
有，就是看一下。这个就它大部分就是超过65%都是在一年之内那个 remove， 然后其中大概有就是1/4左右的人是在6个月之内就拔掉。
6个月之内，所以他最多的症状是那个 bony segment 会晃。
最多他这边的最多的应该是 pain， 就是看他的那个 indication， 就是可能最影响要去拿掉这个 plates 的原因，是因为那个就是有 pain 或者是不舒服的感觉这样子。
因为就是他的整个 study 的 conclusion 跟导向好像是他发现说，如果做 segmental 的话，稳定性会来的比 one piece 不好。然后做 segmental 的话，如果之前是没有做过SRP 的话，那没有做过 expansion 的话，那他之后的这些问题也会比较多，是不是这样子的一个导论？但是他似乎是用 stability 比较弱来解释这个multi segment 的问题点。那但是它的最主要的 removal 的原因，是不是跟 stability 有一些相关？你念完这篇的感觉是如何？
他这篇就是好像主要是只有探讨就是因为 infection 或者是这些 discomfort 就是所要让它就是 plate removal 这样子，然后他的解释应该说，因为就是可能因为 stability 的关系，就是相对来说 segmental 的那个 osteotomy 需要打更多的 plate， 然后还有再加上它的就是 position 可能会比较难放，或者是 position 比较不好，造成它 plate exposure 的情况会比较多，所以才会让它就是removal rates 比较高这样子。
姚医师在线上嘛？我们请姚医师有没有什么样的 comment？
喂，有，就是我觉得 play exposure 应该主要跟那个，确实是跟那个 bone segment 有没有 micro movement 比较有关系啊。那 multi segment 确实风险理论上是比我自己觉得几个因素，一个是泵稳不稳啊，另外就是患者口腔卫生是属于好的还是不好的啦。那另外就是当然其他一些，不过我们例如说抽烟啊或什么这些大概都是 risk factor， 或是 infection 本身就是 risk factor 这样子。对，那我只是觉得蛮有趣，就是说像这样子，好像有点想当然尔的一个概念，其实如果你做一个 review 的话，还是有机会是被接受这样，因为这个期刊也还不错，是欧洲的那个口外期刊。对，所以我看法大概这样，谢谢。
好，谢谢。张晨新哥有没有在？
喂喂，有啊。我们最近发现说，那个牙科啊 ，segmental 的比例比以前多很多，连 class 3都有。那我个人觉得跟姚医师一样，就跟 stability 比较有相关。那目前我个人觉得是说，如果你有放 bone graft， 增加它 stability， 其实我们自己的那个 plate remove rate 是非常低的。那我个人是觉得看不一样的想法是说，因为 segmental 我们做的也不少，但我并不觉得会比 one piece remove 多。那我觉得还有另外一个 factor 就是关窗口的时候，那因为我个人有时候会偷懒，会拜托住院医师请他们关。那有时候他们你看他关完的时候就已经 tear， 然后隐隐约约从 tear 的洞就可以看到 plate 的话，那通常很容易的 exposure。倒是我不知道为什么他们会有疼痛而 removal， 因为我个人是很少见到说所谓的因为那个地方疼痛而把 plate 拿掉的。我不知道在座的各位比我多很多经验，有没有相关因为 pen 而 removal 的这个情形？那还有就是唇腭裂，这个也是一个特别的群组。那他们不管在 advancement 或 bone gap 会比那个正常的 OGS 来的大，而且它常常我们需要做segmental 来 close 那个加上 GPP。那很奇特的是，我们唇腭裂的好像 plate removal 也是蛮低的，倒是可以来比比看，就是说唇腭裂和一般是不是它的instability 会增加，然后 advancement 会增加，而plate removal 的 rate 会增加。谢谢。
谢谢新哥。部长有没有 comment？
我的想法是，像他的 plate removal 15%，似乎是蛮高的。我们的经验里面，不管是唇腭裂的 case 或者是非唇腭裂的 case， 其实在Before One 的地方 plate removal 其实都是蛮低的，跟他的15% 比较，所以也可能是做法不太一样。像我个人的话，特别是我只用3个洞了，就上下各一个 screw， 所以靠近下方的经济板跟薄薄的 mucosa 的地方就更少了。所以我的 plate removal 其实大部分都是长期后看到的plate exposure 了。对于 infection 在Before One也是很少了，所以大概我的经验是这样子。谢谢。
谢谢。陈玉芳医师可以给我们一些 comment 的吗？ 军方医师在吗？那主委可不可以给我们一些意见？
我想跟刚刚部长还有姚医师、张医师意见差不多。我们的 play exposure rate 可能不高。姚医师上次有在 review 我们所有的 case 我们在过去几年做的 case complications， 但是 plate removal 在 MESLA 实在不是很多。那要把这个当做一个 review 来看看是可以，但是似乎因为欧洲和我们一样，是原则上不拿掉。如果像在中国大陆和韩国的话，是routine都拿掉，这变成100%了哈。那这个是 cosmetic reason 或其他 reason 当做一个 removal。那我想以 complication 来讲 ，level 1 play exposure， 除非是像刚才张医师提到的很难关的伤口，或者是extreme 的 movement， 要不然的话，确实这不是一个太大的问题。那么 multiple segment 本来就有可能比较多 plates， 我想 remove rate 高一点，这个是不怎么稀奇的地方了。不过就像姚医师讲一样，这样子的观点也可以来做 review， 我想也可以的哈。如果说他一个小 paper 当出去也是不错。那到时候姚医师那边的 data 可以交给一个 young attending 或住院医师来做一下比较，也是不错。谢谢。
好的，谢谢。可能再问郭医师一个问题，他有没有提到他们的 pedicle 是怎么处理的？这个 great palatine 的 artery vessel 是不是有影响到？
没有好像没有提到 pedicle
没有
的部分。
提到因为在 blood supply 这部分的话，应该对 bone healing 也是会有一些影响，还有它的 nerve 如果有 injury 的话，是不是它本身的 sensation 一定有一些 disturbance？ 那这些疼痛啦，或者是 non-healing、non-union 是不是都会有一些相关性？那在我们的 center 里面，我们这些 pedicle 大部分我相信大概90%以上都能够保留，所以我们的 outcome 似乎是没有很明显看到说这么大量的需要 plate 的 removal。那另外一个点的话 ，location 是不是有关系？就是说它是medial 的或者是 lateral 的 removal 比较多，还是这个部分或许是进一步可以再探讨的。那当然他提到有一些 laser doppler，laser doppler 的话，由于手术当中我们是都做低压麻醉嘛，那低压麻醉之下somehow 应该对这些 laser doppler 应该也会有一些影响，所以术中如果要做这部分的话，似乎是应该要控制血压的状况，才有办法再做进一步的探讨。好，那我们就没有问题的话，我们就进到下一篇。那林医师，你可以分享你的画面吗？
这样子有吗？
有，好，麻烦你开始。
Good morning, everyone. I'm the fourth-year resident. I'm Rolling. So today I'm going to present the paper, Complications Related to OGS, a 10-year experience in oral and maxillofacial training center, published in just this year from a Thailand hospital. So orthodontic surgery is considered a reliable and predictable method in treating dental facial deformities patients with relatively low risk. However, still some complications were reported, including the unfavorable fracture, excessive blood loss, infection, TMJ problem, or the neurosensory disturbances, bone necrosis, ear complication, and so on. So an in-depth understanding in the nature and the influencing factors of complications in OGS is vital in the pre-op consultations and decision-making during the entire course of treatment. So However, previous study revealed a highly inconsistent results, which were still inadequate to provide a true insight to this matter. So this study aimed to provide and critically analyze the demographical and epidemiological data regarding complications in OGS, along with their relationship to various factors in a group of Thai patients. And so patients were collected. Patients who underwent the OGS were collected in this hospital, the Department of Oral Maxillofacial Surgery Center, and from 2009 to 2018. And the exclusion criteria include the patients who underwent the surgically assisted rapid palatal expansion before, or the distraction osteogenesis, and solitary genioplasty, which are involved with the occlusion. And also mentioned that facial bone aesthetic surgery, such as the genioplasty, malaplasty, and angle reduction, were considered as a supplementary procedures in this article. Furthermore, the reoperation were considered as a complication of the initial operation and not the distinct cases. And the complications were classified by this Clavin Ding Dong classification, which we are very familiar with. So a total of 992 patients were reviewed in this article, and after the exclusion criteria, there were a total of 891 patients included. And this figure showed the number of patients who undergone surgery and the incidence of complications each year. And we can see from this figure that most patients were mandibular prognosism. And the author mentioned that the single lower jaw operations were the most frequently performed, around half of the patients, and followed by double jaw operation and single upper jaw operations. And this table showed that about 55% were the cleft patients. And the cleft patient had a significantly lower mean operation time than the normal participants, and a significantly larger amount of blood loss. And also we can see that the inferior alveolar nerve exposure during the BSSO occurred around 32%. And 3.7% had nerve injury severe enough to require a nerve repair. And from this figure, we can see that around 68% of the patients were considered as the grade 1 complications, such as the nerve exposure, back split, minor relapse, post-op TMD, and ear complications, and so on. And 20% of the patients had grade 2 complications, such as the bleeding, required blood transfusion, post-op infection, and 6.6% were grade 3, such as the fixation failure, post-op bleeding, and nasal deformity. And another 4.8% were grade 3B complications, including the major relapse or severe post-op TMD, bone necrosis, and there were no grade 4 or grade 5 complications mentioned. And from this table, we can see that the author found that the immediate post-operative neurosensory disturbance was found in 93% of the patients. And the mean operation time and bleeding volume between those with and without INSD were statistically different. And author also mentioned in the article that 75% of the patients underwent maxillary operation has a neurosensory disturbance of the infraorbital nerve. And from the single lower jaw operation and double jaw groups, also 92% of the patients experienced altered sensation in the area of the inferior alveolar nerve. So from this table, the author also found that the INSD, which is the immediate neurosensory disturbance, is related to the IAN exposure, and also the relapse is related to post-op TMJ problem. However, the author didn't mention this in detail in the article. So moving to the discussion, this study revealed that most of the patients in this article were class 3 skeletal deformity, which is similar to the Hong Kong study, Turkish population, and also the Indonesian population. However, this is in contrast with the result from Finland and Italy, in which class 2 skeletal deformities and mandibular retrognathism were the most common diagnosis. So the author said that this is an implication could be made that the prevalence among the dental facial deformity in European and Asian is different. And also, this study revealed that double jaw surgery results in the highest average operation time and bleeding volume. On the other hand, single lower jaw surgery was the lowest mean operation time and bleeding volume. And the authors mentioned that the maxillofacial structure and the surrounding soft tissue are highly vascularized and contain many vessels, such as the pterygoid venous plexus, the maxillary artery, descending palatine artery, and the retromandibular vein and facial vessels. And they could be this could lead to the results, the reasons of the easily bleeding. And the two cases with the highest bleeding in this study were recorded with a blood loss of 2,800 cc of blood loss and 2,500 cc of blood loss. And it says that these two cases presented with the same adverse events, which is the tearing nasal mucosa and also the tearing descending palatine artery. Another complication were the neurosensory disturbance, and the rate reported before fluctuated from 8 to 85% due to the lack of standardized assessment. And in this article, the neurosensory disturbance rate was 93.5%. And the author mentioned that the high rate was probably because that they include all of the patients who had sensory alteration immediate after the surgery, and the progress of the disturbance after the surgery could not be categorized in detail since there was no standard recording protocol. So further study is required. Also, the relapse and altered occlusion occurred when the occlusion deviated from the initial plan and not correlated by the intermaxillary fixation, elastic training, or the orthodontic treatment. And in this study, facial asymmetry presented the highest chance of relapse, which is 11%, followed by class 2 and class 3 dental deformity. And mandibular osteotomy can change the physiologic balance of the pterygomasseter spleen, especially on counterclockwise rotation of the proximal segment back to its original position. And an intentional angle osteotomy may reduce the tension in the pterygomasseteric spleen that applies the force in the posterior mandible and offer long-term position stability. Other studies report that the rate of the post-op infection was ranged from 2 to 6.8%. And the result of this study also presented a similar rate, which is 4.9%. And the efficacy of the antibiotics was still debated in OGS surgery. And the results in this article revealed that there was no statistical difference in infection rate between the group with post-op antibiotics and without the antibiotic treatment. The operation time has been identified as a possible factor in the previous study. However, in this study, they also found no significant difference in the operation time and the infection rate. So the The treatment planning of the OGS in cleft patient was challenging, and the relapse rate was ranging from 25 to 50% in several previous studies. However, the rate of this study was lesser than 9.1%, and there is no significant difference with the normal individuals. In most of their cases, palatal stents were fabricated and applied to reinforce the maxilla intraoperatively and postoperatively. And also, bone grafting in maxilla was frequently performed to increase the stability of the maxillary segment. And another main complication was the problem with the fixation devices. So it was recommended by the author that a wide bone gap would require interposition bone grafting to promote the healing process. And also a higher rigidity of fixation is needed if the bone was poorly contacted. And also regarding to the bone necrosis of the maxilla, previous literature suggests that preserving the descending palatal artery and the palatal soft tissue was the vital in preventing the bone necrosis. Other factors including the smoking, osteotomy design, degree of the bone segment, and also the soft tissue displacement and soft tissue impingement to the spleen. Several treatments were proposed, like oral hygiene care with the irrigation and also the HBO therapy, the antibiotic treatment, or the debridement. So there were the limitations mentioned by the author, which is because this study was performed in the training center in the OGS surgery, which involved a set of staff member, and also a teams of residents. However, one previous study by this author found that there was no significant difference between the operations done by the residents under supervision and the specialists. So the surgeon experience would be collectively considered as that of a training center standard. In conclusion, numerous factors were reviewed to be related to the complication and could be modified. Operative time was one of the most influencing factors related to bleeding volume, blood transfusion, length of stay, and immediate post-op neurosensory disturbance. With careful preoperative planning, particularly with a virtual treatment planning and 3D imaging and precise surgical technique, operative time could be reduced, followed by a decreasing rate of complications. Thank you very much.
谢谢林医师。请问大家有没有什么 comment？ 周医师可不可以给我们一些comment？
有，我觉得这个文章大概都被很多人写过了啦，就是说对于一个 center 里面它的 complication 是怎么发生的，然后它里面有夹杂一些是 cleft， 但我不知道它是不是有将 cleft 发生率的一些容易发生的 complication 跟 non-cleft 的部分能够个别 isolate 出来说，当我们遇到 cleft OGS 跟遇到一般的 OGS， 甚至说我们在处理2级跟3级或者 OGS 的时候，能够更细微的提供给我们不同的类别的患者看 OGS 的时候常见的 complication 的问题，这样就会更进一步给我们更多的 information。那另外就是，他们现在的这种 paper 大概就是一个大锅炉的去炒所以很难去鉴定说其实how many surgeons involved in the study， 然后整个的时间是从几年到几年的 duration 被 collect 起来的。因为我相信像这样的 paper 应该是会有一个 progressive 或者是 evolutional 的一种 progression 的 change。当时间越近的时候，我相信大家手术的 skill 跟 technique 应该都会有所进步了。所以现在看这种文章，我觉得都还有很多。如果时间拉得很长的话，以前的 complication 被算进来，那是不是那时候的一些时空背景其实是不好的？跟现阶段的话，是不是这些东西就没有的话，应该要来交代一下，当我们的术式或其他的 facility 有进步的时候，有些 complication 是可以被 avoided 的，那将会给我们更多 educational 的一些尝试。那不然的话，其实大国潮从09到18，其实至少我们在长庚我们看到我们很多的进步之下，许多的 complication 都可以被 prevented 的。所以这是我对这样的 paper 的一种的想法。谢谢。
谢谢周医师。似乎我们的 complication 感觉上应该是比他们的来的低一些了哈，而且他的这个一年一年感觉好像没有一些 tendency 或者是 trend 可以发现。那他这个是 number， 但是有没有百分比？就是没有。
他在 paper 里面也没有提到说他这个他只有说他把它秀在这个 figure 里，他就没有再去详述说他每一年发生的 complication 的比例这样子。
那这个部分的话，可能其实大家在做的时候呢，我们比较常遇到的大概还是nerve 的 sensation 的问题。那这个 nerve sensation 的话呢，在他的这个 paper 里面，他只提到 nerve exposure， 并没有提到nerve 的，就是整个有被 injury 到，或者是有被切断的情形。所以似乎他们的 center 里面或者是它这个应该是一个 retrospective 的chart review 嘛，那这些记录里面是不是能够完整的把它记录下来？因为它这边就只有 exposure， 没有看到那个整个切断的情形。
对，没有。然后他在 discussion 的部分虽然有针对这个就是 nerve 的部分去探讨，但是他也只有提到就是像这样，他就只有提到说他们 disturbance rate 是很高，那他也没有特别去详述说跟他里面，例如说到底详细是哪些的 nerve 的 injury， 他没有特别去讲。
我们直接请主委 comment 一下。
确实像周医师讲一样，不同的 stage 你要学习 case， 第100个 case 里面跟最后比方说到1000个以后的 case 会一定不一样。那我们的 staff 大概都超过100个以上，那么都经验都算多了啦。那这些 complication 都可以发生在当然所以我刚 young attending 或是刚开始的时候就比较多一点点。nerve injury 我现在跟病人讲都是100%，开刀后就 numbness， 但很高兴如果没有 numbness 的话就很高兴。那所以这只是因为 exposure 的时候 compression 或是真正的nerve exposure 或真正的 nerve transmission 都有可能了哈。那姚医师大概也都有帮我的 case 在从2000几年到2010几年的 case 有 review， 那你们自己大概都有自己的case， 或许这也是一个像周医师讲一样的，前10年、第2个10年、第3个10年是否有一点改进，这个大概可以 report， 不过这个理所当然大概都可以想象出来。我 over 来讲，我想预防 complications 现在目前来讲都是我们每个人的目标吧。infection 预防，他说literature 说 antibiotics 没有什么影响，事实上我们的 review 姚医师已经有讲过几次，我们大概认为还是有帮忙，可以 reduce。那这个我想大概我们要再证明就要 try， 我想那没有必要。那关于 relapse， 这 relapse 大概他没有讲得很清楚，事实上他说 asymmetry 是比较容易的，确实是因为有 TMJ 的问题，或是 class 2的 relapse rate 应该会比较明显一点。 那么类似这样 relapse 也是针对不同的 pathology 或不同的 category， 你要去 study 比较有意义的，要不然的话，你把这个像这个大锅饭一样把它放在一起，那么 relapse 又讲的是所有的都可能发生。那事实上小小的 relapse 本身对矫正来讲，这是 predictable， 这也无所谓。那么这个 relapse 一定会发生在 early 的时候，那么要定义在什么时候才是你所不能够做的。倒是要 reoperation 才比较好有意义。那 reoperation 的 indication 又不太一样，因为病人要求啦，或是我们认为我们自己的不够好了，或怎么样。所以在不同的 center、不同的 culture 和不同的level 的要求之下，我相信这些所谓的 complication 呢，就会有不同的定义。不过这是一个参考而已了。那我们自己的 data 这么多，我们可以 define 我们自己的一个 category， 或许这在 material 里面呢，我们可以有蛮多的 idea 可以把它表现出来，也表现一下我们的result。过去我们和麻醉科合作，有意无意间把我们的 PONV 表现出来。那这里还没提，但是 PONV 事实上我们的 rate 非常非常低的哈，那会引起大家的一个注意。那类似这样子的 study， 事实上像 numbness， 黄医师花了很多时间在这个 numbness study， 他的 study 就比这个细的多了，他要用各种不同的 test 去做一下 numbness。或许这个也是我们可以展现一下我们自己做的complication 的 study 的方法和预防的方法。尤其刚才林主任已经提到了，事实上对于 nerve injury 各方面的人讲，我们都有我们的小小的经验，或许这也是一个可以拿出来报告的地方。谢谢。
好，谢谢主委。那这个部分 complication 的减少或者是 control 是我们手术当中一直都希望能够最好目标是设定在0那但是还是难免有一些术中会有一些 unwanted 的complication 出来，那我们就大家一起努力那还有没有其他问题或者是 comment？如果没有的话，我们今天 meeting 就到这里，好，谢谢大家。